Greetings and welcome to this video on dengue treatment modalities. We'll discuss about the past, previous, and the current treatment methodologies that are available for dengue. From supportive care to the newer generation antiviral drugs, the discussion on steroids, and then on vaccines. We'll discuss completely throughout as on 2025. This is completely for educational purposes. This is Medicine Beyond Harrison's. Let's get started. So, mainstay of dengue virus treatment. Whenever a patient gets admitted in the ward, the mainstay of treatment is to be supportive care. Supportive care in the sense IV fluids and IV paracetamol to reduce the fever. So, when to admit a dengue patient? When there is no warning signs and it is a mild dengue, clinically stable, vital signs are stable, then you can manage the patient as OPD basis itself. When the patient is having moderate dengue with warning signs or high risk, then it is suggested to admit in the ward for observation. If there is a severe dengue with a shock, bleeding, organ dysfunction, then he may require an emergency or ICU admission. So it is mainly supportive care. It is the foundation. Mild cases require only oral fluids, up to 2 to 3 liters per day. Severe cases carefully treated by providing fluid overload. This is the mainstay of the treatment methodology in dengue treatment. It is the fluid balance that is the most important thing. Pain and fever, if only paracetamol is recommended for fever and pain management, always ensure to avoid NSAIDs such as ibuprofen, aspirin due to increased bleeding risk. So always avoid NSAIDs. Always avoid IM injections because of increased bleeding manifestations. This is the basic protocol for management of dengue fever. When it's a mild dengue, when it's outpatient management, with no warning signs, stable vitals, and able to maintain hydration, you can just educate the patient about the course of the dengue illness. If you want to know more about the course of illness, please watch the part 1 video. And also on the warning signs, you can watch the part 1 video to get to know more about it. So encourage oral fluids, ORS, coconut water, bed rest, and paracetamol up to 10 milligram per kg per dose, maximum of 2 grams per day. Always ensure to avoid NSAIDs, aspirin, or ibuprofen. For moderate dengue in hospital management, there is absence of warning signs, unable to tolerate oral fluids, which is vomiting, abdominal pain, and further presence of comorbidities requires admission. Admission plus baseline lab fluid if possible. Monitor the hematocrit and hemoglobin and platelet counts. Monitor clinical warning signs. Repeat blood test as and when necessary. Oral fluids as tolerated. This is the oral regimen that is always given in the books as well as in the guidelines, such as 7 to 10 ml per kg over 1 hour. That is up to 7 ml over 1 hour. Adjust by response, then up to 7 ml per kg per hour, reduced to 350 ml, then up to 100 ml, then 50 ml per hour. So overall fluid management gets completed within the 48 hours if stable. So no further fluid administration to prevent volume overload. If there is no clinical improvement with hematocrit going more than 5%, then give continuous fluid with 10 ml per kg body weight crystalloids. If the hematocrit suddenly drops, suspect bleeding and local hemoglobin also, then transfers blood 10 ml per kg or PRBC 5 ml per kg. This is the recommended guidelines. In case of severe dengue in ICU management, with there is plasma leakage, shock, respiratory distress, severe bleeding, major organ dysfunction, metabolic derangements. In all these cases, needs an ICU admission and monitoring. In these cases, blood therapy is again the mainstay based on the ideal body weight. Monitor vitals every 5 to 30 minutes when the patient is in shock. Check hematocrit before fluid. If there is bleeding manifestations like in transfuse blood and avoid fluid overload, use inotroph of shock versus despite fluids. So when to stop fluids or taper IV fluids? It is stop IV fluids when all the following are met. That is, patient's pulse rate is stable less than 100, and the BP is maintaining more than 90/60, and MAP more than 65, warm extremities, hematocrit returning towards the baseline, afebrile more than 40 to 24 hours without antibiotics, abdominal symptoms are improving, urine output is normal, no bleeding manifestations. And all these criteria are met, you can carefully decide and stop the IV fluids. So, what is the reason for stopping is if the fluids are given continuously beyond the 48-hour plasma leakage window, there is high risk of pulmonary edema of fluid overload from fluids. So, try to avoid overzealous fluid administration and maintain fluid balance. That is the mainstay. So platelet transfusion guidelines, when there is an active bleeding, always transfuse platelets regardless of the platelet count. If full access with no bleeding, consider only if the platelet is less than 10,000. Before urgent surgical or invasive procedure, if there is a, for example, when a patient with dengue fever develops an appendicitis and you want to take the patient for emergency surgery, then there is necessity for platelet transfusion and maintain the platelet levels more than 1,000. Plain platelet transfusion is completely not recommended and it's of no proven benefit. So investigational therapy, these are the drugs that are in pipeline with antivirals and monoclonal antibodies that are under evaluation. It's based on phase 2 trials are being conducted. Balapiravir, which was previously developed in the phase 2 trial, there is a NADD008 nucleoside analog, adenosine analogs are coming up. There are a few protease inhibitors on the pipeline. There are host targeting antivirals like Celgosivir, alpha-glucosidase inhibitor. Interestingly, lovastatin, a cholesterol lowering agent, has a potential antiviral effect on dengue. Polymerase entry inhibitors like polymerase inhibitors, developed in host target and drugs are also on the pipeline. Even doxycycline have mild antiviral effect on dengue virus. So monoclonal antibodies such as VIS 513 neutralizes all food serotype. These are the promising approaches. Dengue, current activity in dengue on bispecific antibodies target 2 antidote antibody drug conjugates combine monoclonal antibody specificity with small molecule potency. These are the upcoming monoclonal antibodies. The main challenges with monoclonal antibodies, it is very difficult to develop monoclonal antibody that covers all serotypes efficiently. There's high cost, limited availability in endemic zones. Risk of antibody-dependent enhancement cannot be predicted by the monoclonal antibody administration. The need for rapid onset to match disease progression. With all these challenges, monoclonal antibodies are still under development, and hopefully the future is promising with high-end development of monoclonal antibodies which target the dengue virus and also the flavivirus in total. So why early diagnosis and why it matters? Patient care, timely supportive care and monitoring enables better patient outcome. Prevention reduces risk of progression to severe dengue. Also, it alerts the public health system that there is a dengue virus infection going on in the endemic area, and public health authorities can take measures to control the vector. Steroids. So there is a very controversial role of steroids in dengue. So, corticosteroids may help in selected cases of severe organ dysfunction and toxemia. So, there is no much randomized control trials supporting the use of steroids, but majorly used in clinical practices, mainly in the subcontinent, with a large number of effective treatment against dengue virus, with a reduction in toxemia, reduction in organ dysfunction, reduction in decrease in platelet count, prevention of decrease in platelet count and hematocrit, and the overall outcome of the dengue patients have been clinically improved. So, because of the steroids have potent anti-inflammatory effect, suppresses pro-inflammatory cytokines, and because of the immunomodulatory effect, and also reduces vascular permeability, and mainly it stops the antibody-dependent enhancement, the pathophysiology of the dengue fever. So, helps in rapid recovery from the dengue illness. So the evidence remains controversial that large RCTs are lacking. Small studies show possible benefit in severe dengue toxemia, while others show no benefit or potential harm also. So patient selection is very, very important. The potential adverse effects of using steroids are immunosuppressive because it can lead to secondary bacterial or fungal infections, which may become difficult to treat. There can be risks of hyperglycemia and complicates fluid management. There may be GI bleeding, especially in patients with chronic liver disease and ulcers. So use steroids only with careful patient selection and close monitoring. The guidelines for steroid use, mainly supported by the Association of Physicians of India and other sub-local bodies, where there is a early initiation before the development of severe organ dysfunction is more beneficial. This around the third to fourth day of dengue fever illness. Late initiation after the onset of multi-organ failure may only increase complications rather than prevention of toxemia. Commonly, dexamethasone is used zero point 0.3 to zero point 0.4 mg per kg per day. That comes to around 10 to 25 milligram per day for 2 to 3 days. Even 2 uses of dexamethasone clinically had a good benefit, so use it considerably and with good patient selection. Hydrocortisone can also be used and methylprednisolone can also be used in this regard. So steroid monitoring, always check the blood glucose every day, frequent electrolytes, vigilance for secondary infections, monitor liver and renal parameters, strict fluid balance assessment. So individualization, consider severity of organ dysfunction, comorbidities, adverse effect risk, and timing in the illness, and always choose a patient who is compatible with steroids and choose the patient accordingly before giving steroids. So, prophylactic transfusion does not prevent bleeding, as previously discussed. Platelets are given only if there is severe bleeding or extremely low counts before an invasive procedure. So, steroids also, it is mainly two indications, or which are the dengue encephalitis and dengue shock syndrome. In these two conditions, steroids have a better role. So traditional home remedies are commonly used in the subcontinent in India, where papaya leaves are believed to increase platelets, with no studies are supportive of these findings. Papaya leaf can, in fact, exacerbate the gastritis, so hence predominantly avoided. Fruits such as kiwi, pomegranate, dragon fruits having antioxidants can reduce the inflammation. Tulsi and giloy neem antiviral drugs it can also decrease the amount of inflammation. So all these are not scientifically proven. So take it with a pinch of salt. When patients ask about all these kinds of medicines, always say that these do not replace medical care, and they always follow medical treatment rather than these traditional remedies. These traditional remedies may complement but does not replace the standard care of treatment. So there are ongoing many clinical trials with VS5113 efficacy in dengue fever, lovastatin, and multiple antiviral components are in early developmental phase. Future directions are directed against antivirals and development of immunomodulators, monoclonal antibodies targeting multiple envelopes of dengue virus. There is also pipeline in the development of pan-flavivirus therapeutics with dengue, Zika, and yellow fever. So with all these clinical trials are coming up, the future dengue treatment is very promising. So, short note on water control, I always eliminate standing water in the nearby areas. Large size are administered in the containers. Indoor residual spraying is encouraged, and community engagement is very, very important for prevention of prevention of vector proliferation and effective vector control. It is the cornerstone of prevention of spreading of dengue fever. So personal protective measures are always used. Ethardine and IR3535 are used as repellents. Clothing, wear long sleeved clothing in endemic regions to prevent minimize skin exposure and mosquito bite. Always use barriers, use insecticide treated bed nets and window screens to prevent mosquito bite. Vaccines are in the pipeline. One approved vaccine is the dengue vaccine, which is CYD-TDV. Indication only for individuals with prior dengue exposure, that is seropositive IgG seropositivity. So why it is not administered in non-exposed people? Because it can cause severe dengue in seronegative individuals. So hence not administered. The need of equal protection against all four serotypes is the main challenge for vaccine development. There is also a risk of high antibody-dependent enhancement after administration of vaccine, and this also needs to be considered. There is high efficacy is required in seronegative individuals. So these are the challenges in vaccine development process, and it's quite upcoming. Future is promising. So these are the current pipeline vaccines which have failed. One of just registered by the Sanofi and Acambis, and two are in the phase two trials in the US. And there is also a few GSK and Merck marketed vaccines, is subunit vaccine and inactivated vaccines are in the phase one trials. This can come up in the pipeline in 2 to 3 years. So we learned this whole management of dengue fever and the most guidelines based methodology and other things such as steroids and the vaccines part and the vector control methods. The one line is supportive care remains the standard, but the future holds promise with antivirals and improved vaccines. So thank you for watching this Medicine Beyond Medicines. If you have not watched the part one of this dengue fever module, you can always go and check back that one. Let's meet in another video. Thank you.